child with bipolar disorder. Dr. Jensen specializes in resistant mood disorders in private practice in San Diego, California. Also, he teaches on the faculty, the UCSD School of Medicine, and lectures extensively in the San Diego community. Today, Dr. Jensen will speak about the diagnosis of bipolar disorder in children and adolescents, as well as treatment strategies for both bipolar disorder and comorbid conditions. It is great to have you with us this morning, Dr. Jensen. Welcome.
Thank you. Apologies for a little bit late. We had some technical difficulties, but we think those are now. So we'll be talking about child bipolar disorder today. And that begs the question, what is childhood bipolar disorder? Well, like an adult bipolar disorder, in order to make a normal diagnosis, you either need one episode of major depression plus one episode of hypomania, or a single episode of mania is also sufficient to make the diagnosis. Major depression is 2 or more weeks of low irritable mood, plus at least 5 of the following: a change in sleep that can be increased, decreased, or fractured sleep, loss of interest in unusual activities, guilty, negative thoughts or verbalization, loss of energy, impaired concentration, physically slowed appearance, loss of libido at least at appropriate ages, and a change in appetite. A mania or hypomania is characterized by an elevated euphoric or irritable mood, a marked reduction in the need for sleep, often grandiose, sort of God, I'm wonderful, I can do anything thoughts, racing thoughts, loud speech that's difficult to interrupt, meaning pressured speech, an increase in sexual thoughts. Now, hypomania is really the same thing, but with less life impairments, which is very much a judgment call. I want to talk a little bit about the mixed state, which is the third mood state of bipolar disorder. We have mania, we have depression, we have the mixed state. In this state, there's the energy, intrusiveness, impulsivity of a mania, plus a sad, irritable mood of depression. This is an incredibly unpleasant feeling for the patient. And it's in the mixed state that the majority of bipolar suicides occur because it's just so uncomfortable. Now, this year, when the new DSM came out, it gave us a new category of diagnosis, disruptive mood dysregulation disorder. This refers to children with chronic irritability in the absence of meeting criteria for mania or hypomania. Includes many children who will not meet the traditional definition of bipolar disorder in adulthood. In the past, these kids were sometimes called bipolar, and the reason the change in the DSM is the thought that childhood bipolar disorder was thus being overdiagnosed, and this was an attempt to give a label that we could treat under without using the bipolar label per se. Now, sometimes it can be hard to tell whether we have bipolar disorder, disruptive regulation disorder, or shaped behavior, meaning behavior that has been unwittingly reinforced. Bipolar children do show poor behavior often, but they also have the other symptoms that we discussed earlier. They often have a strong family history of bipolar disorder, and they often have clear cycling to their negative behavior associated with the changes in sleep, rate of speech, and impulsivity. If those criteria are not present, we have to consider the possibility that an inconsistent environment is shaping negative behaviors. And the treatment for this includes behavior management for parents, such as consistent environmental expectations, predictability, and appropriate discipline. Now, I think it's important, though, not to blame parents here. If you have a child who is bipolar disorder and chronically irritable, it's very difficult to discipline consistently, and often traditional disciplinary approaches don't really work very well. The shaped behavior disorders include oppositional defiant disorder and conduct disorder. Oppositional defiant disorder, children are usually defiant, argumentative, into tantrums. This can be biologically based, although it's often environmentally rewarded behavior that shaped it. Conduct disorder is more serious. It actions and fights, fire setting, cruelty to animals, and forcing others into sexual activity. So when we diagnose child with bipolar disorder, what type of an evaluation services is required? The initial evaluation should be multi-session, possibly further testing, and possibly deferring diagnosis until you know the child well and have a longitudinal experience with them. Diagnosis of childhood bipolar disorder is based on history, and so a careful history has to be taken from the parents. We review from school, and we want to get the child's perspective on things. In my practice, I take 3 sessions to do an evaluation, and I really find that I can't do it effectively in less time than that. Now, most bipolar children and families require therapy service. And therapy elements include psychoeducation for the family, in other words, learning about bipolar disorder. The Healthy Living with Bipolar Disorder book that's available for free on the IBPF website is a good place to start. Early in therapy, we try to teach the child or teen how to recognize and report mood states, what their triggers are for mania, what behaviors to avoid that make their mood disorder worse. Then we move on to using cognitive behavioral techniques to improve mood and alter behaviors when in specific mood states. Once a child can recognize, oh, I'm depressed, or oh, I'm in a mixed state, then you can try to use skills that you teach to regulate your behavior during the entered mood state. Therapy is not always available. Group therapy, which is not always available, can help with feelings aroused by having such an illness. Medication management visits may be required as frequently as weekly if you're changing meds and the case is really unstable. But generally, once the person is stable, we're doing monthly medication management visits. Now, some children and families require more intensive services, in-home behavior modification work, special education ranging from a simple 504 plan to an IEP. Some will require a self-contained classroom. Some children will require episodic hospitalization for safety, but I don't think we should hospitalize lightly because there are a great many negatives to being in the pediatric hospital. Day treatment programs may be needed in periods of instability, and a small percentage of bipolar children will require residential placement. The treatment methods we use for bipolar disorder include behavior modification, which we already discussed, therapy, medication, and school and classroom interventions. The therapy for major depression should include education about the disorder. It should include maintaining a safe home by securing funds and medications and having regular check-ins regarding mood. Cognitive effective therapy on one's about the self and what's about day-to-day life. People when depressed will have a distorted things as though they out all positive experiences and focus on the negative. In therapy, you learn to use your whole mind to reject negative views of yourself and your situation. Interpersonal therapy focuses on today's issues and practical problem solving. So, problems have you faced this week? How have you addressed them? And the therapist tries to give advice to help with those problems. Therapy for oppositional brain disorder and conduct disorder focus on parental behavior, using positive reinforcement to get more of the behaviors we want to get. There's something called a response cost paradigm that can be used to reduce specific negative behaviors. Essentially, when you do a response cost paradigm, you stay out with a certain number of tokens, we'll say third tokens, each of which is worth several minutes of a favorite activity, be it a video game or a favorite TV show or whatever it might be. Each time the child engages in the negative behavior you're trying to change, you remove a token. And at the end of the day, depending upon how many tokens you have, it's used as currency to buy that favorite activities. Individual therapy can be helpful with older children. Therapy for bipolar disorder should include education about the disorder, learning how to recognize, track, and report mood states, teaching coping skills, safety education, dealing with the esteem and relationship issues that often accompany bipolar disorder. There's a specific type of therapy that you can look at called family-focused therapy, which has been studied and demonstrated to reduce number of hospital days and improve one's functioning. Education and classroom intervention include teacher education about the disorder. You know, many teachers are unfamiliar with bipolar disorder, or they have misconceptions about it. So trying them to learn about it is important. I know I do a bit of speaking to teachers and school nurses on this, and they seem interested in the topic, but it's not a part of their usual background. We try to initiate communication regarding the child's mood state. So in the morning, the teacher is going to know whether they're getting a depressed kid, an irritable mixed kid, or a hypomanic kid. When a child is hypomanic, we use typical ADHD classroom interventions where we structure, provide minimum distractions, predictable transitions, external cueing, warning signals, and a plan for how they exit the classroom if they're unable to function at that time. When it's depressed, it doesn't really feel like doing anything. So you break down tasks into their component parts and you provide encouragement in the classroom. The manic phase of bipolar disorder, medications are used to stabilize. There's a large group of medications called mood stabilizers. These include lithium, Depakote, trileptal, which is a minor modification on Tegretol, and Lamictal. Lamictal is slow to work, so it's not appropriate as a for acute. The typical antipsychotics also have mood stabilizing properties, and these can be quite active in rapidly stabilizing an acute manic child. Examples include Zexa, which is excellent in addressing the sleep disturbance to cause weight gain, Adhd, Bipolar, which is less to cause weight gain, but won't necessarily address the sleep disturbance. Invega, Geodon, Seroquel, another good one for the sleep disturbance. Sabrish, which is relatively new and is good for the sleep disturbance, but typically not used until adolescence. And Clozaril, which is only very rarely used in adolescents and not in children. Medication that depresses of the illness will still can be remarkably effective. Any bipolar person who is suffering from depression probably deserves Lamictal because it is so effective in such a high percentage of cases. Lithium can also be effective in treating this phase of the illness. A antipsychotic like Abilify, Seroquel can also treat the depressive. However, we typically try to avoid antidepressants because to induce mixed states. And sorry, just been informed slides advancing. They're advancing here on, but apparently on you're going to take it and see if we can solve that. We believe we have solved the slide problem, and all of the slides from the talk will be available on the website after the talk is completed. So you can look as you missed on the website. Again, apologies for the technical difficulties. Saying antidepressants should really be avoided in older individuals. Strong tendency to induce states. This is probably the reason why people sometimes become suicidal on adolescents, and this is the reason for the FDA warning of suicide antidepressants. Additionally, antidepressant exposure tends to induce mood cycling, triggering manias, and as I say, it worsens suicide risk. I'm going to mention two tricks that I sometimes reach for in depressed bipolar adolescents. One is inositol. Inositol has been nicknamed vitamin B8 because structurally it looks like a B vitamin. There were 2 studies done on it at a dose of 1 gram twice a day in individuals, and 50% of them responded with an improvement in mood. There are virtually no side effects to inositol, and it can be obtained at a health foods store. Another kind of novel approach is a drug called pramipexole. Pramipexole is ordinarily used for restless leg syndrome or for Parkinson's disease. Another name for the drug is Mirate. And with pramipexole, it essentially increases the firing of dopamine receptors, of dopamine neurons, and thus improves the mood. I would say that in cases that have failed other treatments for the depressed phase of illness, I about 65% pramipexole, so it's something worth doing, and it's, so most physicians are using it. Bipolar disorder comorbid with ADD. Well, this can be a tough dilemma. Is it bipolar disorder? Is it ADHD? Or is it both? In general, if one is only hyperactive and impulsive in the mixed or manic state and not in the normal mood state, then it's probably not ADHD. It's unclear if ADHD is a shaped behavior disorder or bipolar disorder. We deal with additional traits of ADHD, additional behavior modification, and we kind of see what goes. Also, if the bipolar is inattentive, we consider that they may have ADHD inattentive type. Inattention may be the result of medication. And we ask, is the attention present in all moods? Many people are attentive when they're hypomanic depressed because they're quite distracted. Medication treatment for bipolar disorder and ADD was once showed that stimulants are effective, not affecting the mood state. The patient is already mood stabilizers. And my clinical experience is consistent with this study. Generally speaking, once we've got mood stabilized, we can effectively use stimulants like Concerta, Adderall XR, Vyvanse. We can use them effectively to treat ADHD without destabilizing them. And typically when treating ADHD, we reach for the longer agents to having to go to school and to avoid the ups and downs that tend to come with short stimulants. Now, when we look at adults, 50% of folks with bipolar disorder all have comorbid substance abuse. And substance abuse typically starts in adolescence. We don't have any statistics for what portion of adolescents are with bipolar disorder or substance abusers. Certainly a higher percentage in non-bipolar cases. Stimulant use is uncommon with bipolar folk. People will use cocaine or snort their Adderall or take high doses of stimulants in order to trigger a mania if they find their manias to be pleasant. The club drugs like GHB, ecstasy, and ketamine, or Special K, can also be abused and strongly tend to destabilize the mood. Hallucinogens like LSD or mushrooms are not uncommon, and they tend to make bipolar people even more psychotic than make non-bipolar people. Marijuana should not be underestimated. Here in California, marijuana is all but legal via the medical marijuana card. To meet anyone in California who doctor to get a medical marijuana card who didn't get one. So essentially, you automatically get one if you seek, even if you have a condition like bipolar disorder, which is made worse by marijuana. There are two kinds of marijuana that are out there on the market right now. One is cannabis sativa, the other is cannabis indica. Cannabis indica is the calming, mellowing marijuana that people remember from the 70s. Cannabis sativa is stimulating and can be cocaine-like in its effect. I've seen a number of cases where people became very psychotic on cannabis sativa when they were bipolar, and it really tends to destabilize the mood. It's a major problem if bipolar folks start using it. Prescription killer abuse like Oxycontin, Tylenol 3, and Vicodin occasionally pop up in bipolar individuals. And alcohol abuse is common, and it seems to be more common in people who suffer of mixed states. So, in summary, we don't really know about recognizing in childhood bipolar illness. We always try to mitigate symptoms with behavior modification, therapy, and educational interventions. Many bipolar kids and adults can function normally with medication and the adaptive skills that they learn in therapy. At this point, I think we can open it up for questions. Debbie will let us know how to do that. Well, the first question I have here was from someone who noted that the slide is working. Hopefully that problem has been solved. Are there other questions that folks have?
Yes, thank you, Dr. Jensen. Hopefully you can all hear me. Okay, first question. You mentioned Lamictal is quite effective. Is there any difference between the generic and generic of this medication? All generics the same for bipolar?
Well, that's a great question. In general, pretty good luck with the generic Lamictals. Having said, I have seen a handful of people who did seem to absorb the generic well, and I know because I measure Lamictal levels, we switched them to generic, they stopped doing well, and when I measured a level, it had dropped what it was on the brand name. Now, you can make up for that if you follow blood levels and stick with the same generic. If you have a generic that will absorb, you can just go up the dose and get enough in the system. But what you don't want to do is rotate generics because there can be different.
Yeah, he has kind of like. Right. We're sorry, we're just having a few complications with the sound. We'll be back shortly.
Tom, are you on the line? Tom, do we have you?
Yeah, I can hear you. Can you hear me?
Yes. Okay, we're now back. We apologize, everyone. So, Tom, I'm sorry, you cut out in the middle of your answer about non-generic or generic question.
Let me read that then. In general, I've had pretty good luck with the generic lamictals, but I've had a handful of people who, when we switched from main generic, weren't absorbing the generic as well. I knew it to be the case because their mood got next question.
Can you hear me?
Yes, I do. Can you hear me?
Yes, okay. Next question is, and I'm not sure if I'll pronounce correct, bromocriptine. Give this as primopexine.
I think you mean bromocriptine.
Yes.
There's no literature on using bromocriptine to depress bipolar illness. not attempted to use it for that purpose. Having said that, amitriptyline also is a dopamine agonist. There's reason to think that it might work. I just haven't ever done it, nor have I seen any articles on it.
Great. Thank you for that, Anna. The next, what are the blood indicators monitored for take Lamictal?
Well, in general, you don't need to monitor for liver function or blood counts on Lamictal. Routine work is not a part of using Lamictal. I do like to measure levels. I aim for blood levels of 6 to 10 nanograms per deciliter. In my experience, that's where I get the best. Now, you won't find literature on blood levels for bipolar disorder of Lamictal. The literature levels is based on epilepsy. But the way I got it, if it's measurable and it's low and still on.
Great, thank you. The next question, again, we have a drug that I must pronounce. Your comment on the use of cabambarmapine as a mood stabilizer. We're a developing country and it tends to be more available than Acels, CM, and Valorate.
I think you mean carbamazepine, which is the generic name for Tegretol. And Tegretol or carbamazepine is a pretty effective mood stabilizer in terms of treating this. It's a little bit low, so I prefer an atypical antipsychotic for acute mania. I prefer lithium for acute mania. But carbamazepine isn't, and the drugs are not available. Carbamazepine is not very good at depressive bipolar illness. It's more effective on mania than it is on. Next question.
Thank you very much. Answer next. Use that for girls. How do you deal with the risk of polycystic ovarian disease?
Well, I almost never use valproate in girls because it can lead to polycystic ovarian disease. So I tend to reach for like trileptal valproate. Now, we've tried everything else and none has worked. We may take the risk of polycystic ovarian disease, bipolar disorder is severe enough. Don't use it lightly.
Great, thank you. The next one, at what age should you be looking at bipolar as a diagnosis? I was told they shouldn't consider until a child is much older.
Well, if a person has had a mania or hypomania and a clinical depression, then age is not relevant. Interesting, I finished my child psychiatry residency at Stanford 25 years ago. I went out into private practice, and I thought there was such a thing as childhood bipolar disorder. So I moved to rural Maine. I was running a teenager psychiatry unit, and on 2, I got a call, would I please admit this 9-year-old boy? And this little boy hadn't slept for 3 days, was hyper-religious, hypersexual, walking fast and in a pressured way, and was classic manic. Now, when it's like that, right, that he's only 9, can make a bipolar diagnosis. Again, so it's based upon the symptoms, not the age. Now, the difficult thing, though, is that often children who are destined to be bipolar don't have a first mania or depression until adolescence. So we may end up treating them under this label, disruptive mood dysregulation disorder, but that's the reason that was created.
Great, thank you. Can you please give example of irritability?
Sure. The child may respond excessively to correction, become very, very angry about things, make another child angry. They may be hypersensitive to noise or stimuli in the environment, resulting in angry outbursts. And so essentially it presents anger, response to stimuli that can cause anger. Or I shouldn't degree of anger.
Great, thank you. Next question. Have you tried cysteine with children, and also do you use fish oil?
I have not tried fetal cysteine in children. I don't have experience in that. Fish oil I do use, more in adolescents than in children. There were studies at Harvard in the 80s that showed that adding fish oil to mood stabilizer regimen often helps the depression. Now, it didn't tend to fully treat it, but it tended to help it. And fish oil is generally good for you, so it's not going to hurt you. Now, the dose used in these adult studies was 1 gram 3 times a day. So we're talking about pretty high dose fish oil.
Thank you. Are there any medications to treat older children that do not require blood levels?
Yes. Can get away with any of the typical antipsychotics without blood levels. You can use Lamictal to a point without blood levels, but if you want to move to higher doses, you should measure a blood level to see. Now, valproic acid or Decote requires blood levels. Sorbitol or carbamazepine requires blood levels. Trileptal does not absolutely require blood levels. So that's one that you can get away with doing without blood levels. But mostly typical antipsychotics used if we want to avoid blood levels.
Great. The next question, I've always been a bit nervous of giving a child under 16. Should that be a last resort? If is that on a developing brain?
Well, the medications appear to be safe in childhood. Most of these drugs that we use in childhood disorder have been for years epilepsy and turned out to be safe in that population. Now, to admit that, drugs called Lamictal have only been on the U.S. market for about 20 years, so it's possible that when they're on the market for 30 years, sides will crop that we didn't know. However, being an unstable bipolar in childhood causes a lot of problems with development. So I think you weigh the risks of not treating the risks.
Great, thank you. Next, my son has severe psoriasis and is currently taking a Humira shot twice a month. Does medication impact on bipolar?
That's a great question. Theory, Humira, like a steroid, like prednisone, could stabilize the mood. It could to more mania in the mixed state. Having said that, I had a bipolar patient. So I'm answering really based upon theory, not upon knowledge. And to my knowledge, there are no reports of adverse effects of Humira in bipolar people, but so few bipolar people have gone on Humira that it may not have cropped up.
Thank you. The next question, would you make the diagnosis of bipolar and 3 current depressions, but no mania yet, with mood stabilizers? Worry about metabolic syndrome when you use atypical in children?
Well, if I'm seeing depressions, initially I'm going to treat with antidepressants. In children who really bipolar, what you often see is that antidepressants make them worse or them in mixed states. And at that point, I may say, gee, I think this is a bipolar spectrum depression that just hasn't had the first mania or hypomania, and for a mood stabilizer case. Concerns metabolic syndrome, which references changes that happen when one gains a lot of weight. Concern about that on atypical antipsychotic are real. Now, not on an atypical antipsychotic gains weight, so you can try it and see if they gain weight. But as a general rule, if they're in an mania, and there's a reason that I have to stabilize immediately, I would reach for a traditional mood stabilizer over an atypical psychotic first.
Great, thank you. What do you advise for weight treatment to some bipolar patients?
I wish there was an answer, something that was effective. Essentially, it comes to diet and exercise. But it's very difficult to diet when you're chronically. We try to move, if it's related to an atypical antipsychotic, we try to move to Abilify or Sacris or Latuda, which are less likely to cause weight gain. Having said that, these two can cause weight gain. We try to towards mood stabilizers instead of using atypical antipsychotics in order to get off the atypical antipsychotic.
Thank you. Next question. Can you speak a little about trilevel? Have been the only drug that was effective in an 18-year-old bipolar client mania.
Trilevel, generic name, is a modification on Tegol or carbamazepine. There were two multi-center trials in bipolar disorder relatively early 1980s in Europe. It has not become popular here in the U.S. Doctors are not familiar with using it for bipolar disorder. There's a subgroup of bipolar people who respond to trilevel and don't respond to anything else. It's one of those that's worth trying if you've seen other mood stabilizers and they haven't been effective. It's a side effect-free drug. I mean, every drug has side effects, but it's generally well tolerated. There aren't any significant drug-drug interactions. You can stack it in with other mood stabilizers, no problems. So, it's for some people.
Thank you. Next question. They say that is the second brain. Probiotics and specific diets have been to help children and adolescents with autism. Do probiotics and diets have any positive impact on those with disorder?
I don't know. I don't think it's known. However, I've heard anyone with probiotics, so it's not unreasonable to try them and see. I don't think, though, that I would take off of their mood stabilizers and it's with probiotics alone.
Great, thank you. Can you touch more on blood levels? I often hear psychiatrists say this, but have not understood what this means, or therapeutic levels.
Well, essentially, how much drug is in the bloodstream has been studied in certain disorders, and found that a particular level works optimally. And so the blood level is used to basically answer the question, is the dose right? So, for example, in the case of lithium, 0.7 to 1.1 is the range that we aim at. At below 0.7, it tends to be less effective. At level above 1.1, we tend to see more side effects. And so the blood level is essentially used to minimize effects and optimize positive effects.
Great, thank you. Can you talk about the relationship between self-cutting and bipolar disorder?
Yeah, a lot of bipolar folks do cut. My experience is they cut first day. And the cutting typically does not represent suicide. Rather, it's an attempt to convert psychological pain, physical pain, which is more dealt with. So, have someone to cutter. We both work on behavior different strategies to help mind other coping skills, but that's cutting. And we we also try to make sure we've optimally treated the mood disorder.
Okay, thank you. Next question, is Cerebolin NAC effective for a bipolar person?
Can you do that for me?
Or Cerefolin.
I don't know the answer to that. Sorry.
Okay, next question. What is the role of lithium with children and adolescents?
Well, you know, lithium has often been the gold standard in that it is very effective for bipolar disorder. However, we typically don't use it as a first-line drug in children because they have a great tendency to develop thyroid damage from lithium than do with. So typically we reach for other mood stabilizers before we reach for lithium, but there is a sizable percentage of bipolar folks who only respond to lithium. So if the other strategies haven't worked, and again, we risk-benefit analysis of the risk of thyroid damage versus the risk of having them stable, and we make a decision.
Great, thank you. I am a mom who's never dealt with mental issues, nor my husband. His daughter was diagnosed with bipolar 2 years ago. Now being aware, I'm seeing significant flags in both our 12-year-old son and 14-year-old daughter. I also have a 16-year-old with Asperger's, but my oldest daughter is fine. How common is it to have siblings also bipolar? Or am I being really sensitive as a parent or paranoid?
Well, it's relatively common for siblings of bipolar kids to have bipolar disorder. You know, my experience with it is it's about 20%. And, you know, obviously you don't want to become so paranoid about bipolar disorder that you see it under every rock. But certainly if a student is showing symptoms of hypomania or depression, and they have a bipolar, have a very high suspicion that it's bipolar.
Thank you. The next question. Young son has ADHD, and listening to your response to a previous question regarding irritability, this resonated with us. We see that within him. Could you touch more on a manic and what to look for?
Sure. A couple of comments. One, with the ADHD and the irritability, the question I have is the child only irritable late in the day when the medication is worn off? Called rebound irritability and its phenomenon, not necessarily indicative of a mania or a mixed state. The hallmark of a mania is a markedly reduced need for sleep. The other really common symptoms are racing thoughts, which a child may or may not be able to tell us about, rapid pressured speech, increased physical activity. So they'll look more ADHD than they normally would during the course of a mania. So essentially, the ADHD symptoms are what we see when the child is in a normal mood. And if we see more of those symptoms on particular days associated with a sleep disturbance, then we're probably also seeing a mania.
Okay, great. Thank you. The next question, what are the side effects of lithium and why it's called a DIRTH drug?
A what drug?
DIRTH, D-I-R-T-H?
I've heard it called that, so I don't know the answer to that. Side effects of lithium include frequent thirst, frequent urination, which can present as bedwetting in children. It includes, of course, hand tremor that can develop, particularly if the levels are high. Thyroid damage is a risk with lithium, and kidney damage is a risk, although I must say that I have not seen cases of kidney damage in people who didn't overdose on lithium. So I think the risk of kidney damage is much lower than we used to think that it was. Every pill in the PDR can cause diarrhea. Lithium often does that. Headaches and allergic reactions can also occur. So allergic reactions to lithium are typically not to the lithium itself, but rather to the dyes and fillers in the pill. So if you get an allergic reaction on one brand of lithium, you have your pharmacist look up what dyes and fillers are in it and try to come up with another brand that doesn't have the same ones.
Great, thank you. Apparently there was a misspelling. The question was dirty drug.
Oh, a dirty drug.
Dirty drug. Yes.
I think it's called a dirty drug because it does so many things in the brain. It hits so many different receptors that it's sort of like a pharmacology shotgun. So it's not hitting some one or two very specific receptors. It does a lot. And the reality is that we don't entirely understand why lithium works for bipolar disorder, which of its many effects are responsible for it working.
Great, thank you. In your experience, how successful are you in getting an adolescent to own his illness, especially when he was getting ready to leave home for college?
Well, my experience with such adolescents, they've been in treatment for a while, is that, about 90% of them own it and are willing to make healthy lifestyle choices related to that. That's in my practice. The majority are willing to do. However, make a diagnosis in someone new and you haven't had a long time to work with them and they're heading off to college, that's often a source of difficulty. Also, substance users are often reluctant to give up their substances and as a result tend to do poor. Particularly marijuana, there are all of these websites out there that say marijuana is good for everything. And from time to time, I meet a bipolar kid who says, I read that marijuana was good for bipolar disorder, which it isn't. But they tend to believe their pro-marijuana website over what a doctor tells them.
Thank you. Is there a correlation between self-mutilation / bipolar disorder and trauma during early childhood, especially sexual abuse?
Well, cutting is common in people who have been sexually abused and is also common in bipolar disorder. So the two together would increase the risk of cutting even more. So yes, there is a correlation.
Thank you. If there is no past family information available or established, does it get harder to accurately diagnose bipolar disorder in children?
Well, if the child has had a classical mania, then no, the absence of family history doesn't really come into play. Where it becomes more of an issue is the child who's been depressed, maybe a hypomania, maybe not. You're kind of on the fence. And in those cases, family pushes you towards a trial of stabilize. So not having the family history in those cases makes it a little more difficult to know what to do.
Thank you. The next question, is it difficult to distinguish between bipolar disorder and borderline personality disorder?
Well, the borderline does have an unstable mood, but they do not have classical manias and hypomanias. They're hyperreactive to loss, to rejection. They tend to sow chaos in whatever environment they're in. They get everyone fighting with everyone else. So there are differences. The bipolar disorder person tend to have a more solid identity than the borderline person. However, the reality is that you can have both disorders.
Great, thank you. My son has bipolar disorder and his hands shake and have been shaking. He started taking his medicine over years ago. Which medication is the main cause of his shaking? And I believe you talked about the Serafolin NAC. Is that effective for a bipolar person? I'm not sure if that's what this young boy...
Yeah, I know it's effective for a bipolar person. Now, what a list of medications that is on?
I don't. I need Jean, you can type that question in, and I will ask that once again. I'll move on to another question for now.
Okay.
What is Latuda, and how does it differ from the other drugs used in bipolar disorder, and is it used with children?
Latuda is a new atypical antipsychotic. It's not typically used in children. It's typically used in adolescents. Like Safarist and Adhd, it is less likely to cause weight gain than the other atypical antipsychotics. Safarist and Abilify is often effective in the depressive phase of the illness. And for whatever reason, we don't know why. Some bipolar folks will do better on one atypical antipsychotic, and others will do better on another atypical antipsychotic. So, for example, if you tried Abilify and it didn't work out, you might try Safarist, or you might try one of the other atypical antipsychotics like Latuda. Next question.
Okay, thank you. What do you suggest for a person that may have all of the bipolar symptoms yet are not really examined?
Well, that's a tough one, you know. Most commonly, the family is the one that's concerned, and the person with the illness either doesn't think anything is wrong or is fearful of getting a diagnosis. What I would say is that you, alongside them, you express your concern, you try to encourage them to seek help, but the reality is the person has to want help in order to be helped.
Thank you. Okay, back to the question beforehand. This young boy is on for 5 Lamictal, Lexapro, Abilify, Vyvanse, Soil, and the Serafolin NAC tablets.
Well, the most likely thing that he's got tremor related to the lithium. That's by far the most common cause of tremor of medications. Now, if the tremor is severe, and if he's in adolescence, and even in children sometimes, we can reach for a drug called propranolol to suppress tremor. Propranolol is actually a high-pressure medication. It blocks an adrenaline receptor that is also involved in hand tremor. So some people will reach for that if the person needs lithium and can't do well on a lower dose. The tremor tends to be dose dependent, so at higher blood lithium levels there's a worse tremor than at lower blood lithium levels.
Excellent, thank you. The next question, do you recommend using SAD lights for bipolar patients who get down in the fall and winter? Yeah,
the full spectrum alarms that are used to treat seasonal affective disorder and bipolar people do cycle to a depression in the fall and winter. What I would say is I recommend using them with caution because they'll put some people in a mixed state, and if you overdo, they'll put some people in mania. So you start with about 5 minutes a day phototherapy, and then go up in 5-minute increments once a week until you find the amount of light that was optimal. You monitor for mixed states and manias.
Great. Next question. As a school psychologist, you're often not to deal with mood disorders. What are some of your thoughts on how schools are helpful and supportive in treatment of bipolar?
Well, I think they can encourage the parents to seek competent help for their child. They can do educational programs to help the teachers understand the disorder so that they can be more ECT is electroconvulsive therapy. It used to be called shock therapy. When medications fail, it can be effective treating mania or severe depression. However, I have to say that I count on one hand the number of bipolar people that I've sent for ECT over the years. I've treated about 2,000 people with bipolar disorder. In general, one can treat it effectively with medications, not have the memory loss issues in ECT.
Great, thank you. We have one last question, and is since the family has a more objective view of the patient's behavior, how do you go about their input for working with the patient?
Well, I can hear their perspective.
Wonderful. Thank you so much, Dr. Jensen. We appreciate your time and your insight. And again, we do record the webinar, have recorded it. It will be archived on our website this afternoon for future viewing. And I wish you all a wonderful day. And thank you again, Dr. Jensen, for joining us.
Thank you.